Hi, this is Dr. Duncan Ferguson, and we're going to talk in this presentation about emetic drugs, anti-emetics, and prokinetics. And I first want to give a little bit of a disclaimer. Managing the motility of the GI tract, which is normally managed by the autonomic nervous system, is a complex business and difficult to sometimes manipulate pharmacologically. But let's launch into how we can try. And of course, all of this is going to be supplementing dietary means of alteration of GI motility, which often is the most natural way to restore or adjust the problems of motility in an animal's GI tract. So with that disclaimer, this graphic would suggest that things are simple, but as I implied, not this simple. So let's first talk about emetics. So a situation where you might want to have an animal vomit. This is, of course, something you should attempt to do if you have some toxin the animal's ingested and it's safe to have it vomited. So drugs that tend to be emetics include opioids that stimulate the chemoreceptor trigger zone, and they do so if they are rapidly, uh, they do not rapidly penetrate the emetic center, but in drugs that opioids that do, like fentanyl, they can be used for around anesthetics for pain relief because they rapidly suppress the emetic center. Um, the main class of drugs where we see emetics are the dopamine agonists, and these were obviously directly stimulating the emetic center. Apomorphine is a classical example where you have it as an injectable product, an oral tablet, and sometimes this oral tablet is given subpalpebrally to induce vomiting. And a more recent product, ropinirole, Clevor, is an eye drop and is used for dogs. In cats, vomiting is stimulated by the alpha 2 agonist, xylazine. So let's now turn our attention to drugs that manage vomiting. Firstly, a few principles for any animal that's vomiting. You probably want them to be given nothing per os for 24 hours, so you're not stimulating the GI tract to just vomit that back up. And if the animal has any fluid, electrolyte, or acid base imbalances, you want to correct those. And then obviously you're looking for a cause of the vomiting. Managing vomiting is really a managing of symptoms, of signs. And so you want to reverse any underlying known causes and consider that antiemetic drugs, when you give them, can also have side effects. And that vomiting itself is a response of the body to try to get rid of toxins, for example. Okay, in this graphic, we summarize the various pathways to stimulate vomiting. And everything is coordinated via the emetic center. And the first most direct stimulus that you can have of the are the basically via the pain, the vagus and sympathetics, the stimulus from the GI tract, or psychic pain, sort of mental pain, if you will, uh, that can then directly feed to the emetic center and lead to vomiting. And then we have the chemical stimuli that get processed through the chemoreceptor trigger zone, CRTZ, through the emetic center. And all of these lead to the vomiting reflex that's managed through efferent motor nerves, spinal and phrenic nerves that stimulate the abdominal muscles and the diaphragm for the classic, vomiting reflex. So in this detailed table, this is something really like probably to study for a while or print out and have on hand when you're thinking about using an antiemetic. But I first want to focus on telling you what locations various drug classes work. We call the emetic center, the vestibular apparatus, so nerve 3, um, and the periphery. Some of these drugs will work in the periphery to alter GI motility to diminish the tendency for vomiting. So we have also the chemoreceptor trigger zone, and then EC is obviously emetic center. So we have these classes of drugs, the phenothiazines. Examples are given to the right, antihistamines, H1 antagonists, that is, and you notice some of the phenothiazines can be also antihistaminic. Anticholinergic drugs like the seasickness drug scopolamine, so those are antimuscarinic. Anti-serotoninergic drugs, dilazetron and ondansetron, and anti-dopaminergic drugs like metoclopramide. And then finally, the more recent class of drugs that's been put on the market and seems to be dominating clinical use right now is the neurokinin antagonist, meropetant. And so I'll let you look at the list here, and obviously, if you see the most recent drug, it has very few cross-side reaction against other receptors, receptors being dopamine 2, histamine 1, muscarinic, and neurokinin and serotonin 3. So you can look at those drugs that have, pure anti-emetic effects, those that might also be sedatives or tranquilizers, those that would be effective against the motion sickness associated with the vestibular apparatus would be often histaminergic, antihistaminergic. And so this is what you want to be looking at as you choose a drug for any particular patient. So let's now turn to various scenarios where we have known causes of vomiting. And let's start with those that are circulating drugs or toxins that might be targeting the chemoreceptor trigger zone. And here's where dopaminergic antagonists like metoclopramide or domperidone are very effective, or phenothiazines, particularly if the animal can tolerate some tranquilization, or any antimuscarinic drug. These would actually, drugs like chlorpromazine would be preferred in cats. In addition, serotonin 3 antagonists, ondansetron and dilazetron. And we move to motion sickness, basically any stimulus of the vestibular apparatus. The most effective here are antimuscarinic and antihistaminic drugs, such as scopolamine, atropine, or any of the antihistamines that have been listed before. Then we have any situation where there's visceral stimulation or that's causing direct stimulation of the emetic center. These we call broad spectrum because the emetic center is sort of the final common pathway for all of the causes of vomiting. And so here we use antimuscarinics, we can use phenothiazines, and we can use the newer drug neurokinin receptor antagonist, meropetant. And then sometimes we have a situation where we want to enhance gastric emptying. We have drugs like metoclopramide that not only will impact the chemoreceptor trigger zone, but also can enhance gastric emptying. So there's two mechanisms, both central and peripheral, that a drug like that can work. And then the serotonin 4 antagonist, tegaserod, is also something that can stimulate gastric emptying. You can imagine that if you can stimulate gastric emptying, then it means the stomach is not full of something that can then be ejected under vomiting reflex. So I thought it'd be worthwhile taking a look at the physiology of gastric emptying one more time and do it in this graphic. It's complex, but I'll walk you through it. The most important thing when it comes down to drug therapy is understanding that the decrease of gastric emptying can be stimulated by sympathetic agents and inhibited by parasympathetic agents. And these are normally impacted by things like through the parasympathetic nervous system reflexes, the antral stretch mechanism through intramural plexi, CNS, and then through regulation of the sympathetic and parasympathetic pathways. Then you have, of course, the impact of food. And so, in addition to stretch, you have acid managed through secretin, fats through cholecystokinin, hypertonicity, and amino acid and peptides managed through gastrin that can also cause decreased gastric emptying. So that's why obviously when you have a meal, all of these things are in the GI tract in the stomach, and you have a need for that acid to be secreted and also for these agents to slow down gastric emptying so that the acid can process whatever's in the GI tract. And so that's the dietary impact of what you do with regards to managing an animal that's vomiting is going to be impacted by previous diet or whether you try to feed them in the meantime. And so obviously this is one reason why we try to keep an animal NPO. The all of these signals back to the stomach, the antral part of the stomach, are through duodenal receptors, so that they presumably are being picked up. These compounds are being picked up after leaving the stomach, and they provide this sort of negative feedback to say, "Hey, slow down. We need for you to let us digest a little bit more, etc." So that's an overview of gastric emptying, and it's something that you ought to keep in mind when you think of diet with regards to emetics and prokinetics. Okay, another complex slide that I'm going to walk you through. We already talked about the impact of sympathetic nervous system, more or less inhibiting GI motility, and parasympathetic stimulating GI motility. See these pluses and minuses. But let's take a look at what's going on, sort of more or less, at the smooth muscle uh, site, and the particular neurotransmitters that will have excitatory effects include acetylcholine, vasointestinal peptide, and substance P. And you'll see them highlighted in red: substance P, vasointestinal peptide, and acetylcholine is at all of these synapses on the cholinergic side. Inhibitory is nitric oxide, and the opioid enkephalin, ATP, and serotonin. And so we want to keep this in mind. You can see the inhibitory effects of serotonin, uh, of enkephalin, directly on the smooth muscle, and we'll talk about this when it comes to colonic motility, how important the opioids can be. ATP, purinergic neuron inhibitory, and serotonin inhibitory. So all the effects on the smooth muscle are what we're looking at in this slide. And so um, keep these neurotransmitters in mind. We'll bring them back up again when we talk about the actual drugs that fit into each of these classes. So let's start from the mouth and go aborally, so to speak. Esophageal motility is very difficult to manage in severe disease, but when we try to do it, we need to keep in mind the innervation. Dogs have striated muscle in the esophagus, so there's nicotinic innervation, nicotinic cholinergic, and cats have both striated and parasympathetic and smooth muscle, I should say, that is nicotinic and parasympathetic innervation. So what drugs do we use? We use bethanechol, which is a muscarinic cholinergic agonist that is you can attempt to use for inducing more esophageal motility. We have the drug cisapride that's probably used more for dogs, um, for and then for the purpose of esophageal motility, and then it's better for cats for gastric movement for some reason. It's been since this particular drug, but other drugs in its class, this particular drug was removed from the U.S. human market due to heart arrhythmias occurring after drug interactions. Okay, let's use this slide to summarize the sites of action of prokinetic drugs. And to some extent, this is a review of the actual physiological control, but overlaying the kinds of drug classes that will impact the GI smooth muscle and its motility. So let's start with the cholinergic agents. So here's the muscarinic receptor, and bethanechol can directly stimulate it. So anything with a green is a stimulatory effect. Anything that's red and with a block is a uh, receptor antagonist, in this case, like metoclopramide. So acetylcholinergic effects, we have those that can be acetylcholinesterase, which increase endogenous acetylcholine in the neural cleft, like neostigmine, that can also essentially, this blockade of the cholinesterase, that's what this intends to show, is also stimulatory for muscle contraction. Then we go to the nerve that is the cholinergic muscarinic nerve that's feeding this muscle. And let's look at the impact there. Let's go back to the dopaminergic antagonist, metoclopramide. Presynaptic dopaminergic neurons have this normally stimulatory effect to lead to anterograde movement of the intestine, where metoclopramide can, depending on where the location is, can block this effect. We have the drugs that are motilin receptor, like erythromycin, that can stimulate the muscarinic nerves and stimulate motility. We also have drugs like cisapride that can, through the serotonin 4 receptor, can stimulate motility and anterograde motion. And it's worthwhile mentioning that all of this is managed through contraction, stimulation of the release of calcium through the smooth endoplasmic reticulum that leads to contraction of the smooth muscle. Okay, some clinical details about prokinetic agents and their indications. Where we want to increase gastric emptying, we'll see the use of cisapride or a serotonin 4 agonist, more in the dog than cat. Ranitidine, which actually has some anti-cholinesterase inhibition, or erythromycin, particularly in the dog, which is a motilin agonist. When we want to increase small intestinal motility, we have metoclopramide, a dopamine 2 antagonist, a serotonin 4 agonist or serotonin 3 antagonist, or something like cisapride, a serotonin 4 agonist. Again, more useful in the dog than cat. And then when we get to colonic motility, you can see the serotonin 4 agonists are used, prucalopride, cisapride, and misoprostol would have to be given rectally, and erythromycin. It's effective in the dog, but not in the cat. So that brings us to the motilin receptor agonists, which, from all intents and purposes, bring us to macrolide antibiotics that happen to be motilin receptor agonists at dosages that do not inhibit microbes. So they're lower than the antimicrobial concentrations. And their mechanism is that they stimulate migratory motility complexes and antegrade peristalsis in the proximal GI tract. They stimulate cholinergic and non-cholinergic neuronal pathways that increase motility, and we see their use, their indications in gastroesophageal reflux, reflux esophagitis, and colonic atony. And examples of this, as I mentioned before, are erythromycin, which is shown here, the macrolide, and a related drug, clarithromycin. And finally, we have prokinetic agents that are anti-cholinesterase inhibitors, ranitidine or Zantac and nizatidine, two histamine 2 receptor antagonists that have prokinetic activity because of this crossover activity to block acetylcholinesterase. They can inhibit gastric acid secretion, but their main effect is for motility is in the proximal GI tract. They stimulate GI motility by increasing the amount of acetylcholine available to bind smooth muscle muscarinic cholinergic receptors, like any acetylcholinergic agent. We mentioned the sort of prototype being neostigmine.